The strongest evidence for the use of IVIG comes from a 2022 double-blinded RCT study in women who had 4 or more unexplained pregnancy losses, which found that using high-dose IVIG every 4 weeks at about 4 to 5 weeks of pregnancy significantly improved live birth rates compared to placebo. Welcome to my fertility podcast, Superhumans.
A space for honest conversations, expert insights, and stories of resilience.
Whether you're just getting started on your fertility journey, facing challenges, or looking to educate yourself, you are in the right place.
We are Dr. Mavis Garcia
and Dr. Wise,
fertility specialists at Markham Fertility Center located in Markham, Ontario, Canada.
Think of us as your biggest cheerleaders. Let's demystify the world of fertility together. It is another Tuesday, and we are releasing another episode of my fertility podcast. On today's episode, we are going to be getting into the nitty-gritty of treatments for elevated cytokines. If you don't know what cytokines are and you don't know anything about the immune system, please check out episode 78, where we talk about reproductive immunology in general, testings and treatments, and episode 83, where we talk about LADs and LIT treatments. And of course, if you don't know what cytokines are, you don't know anything about the immune system, please check out episode 87, part 1, as this is going to be part 2 of this mini series within a series about cytokines. We've got lots of information, lots of studies to tell you about today. So let's get rolling.
Absolutely. So let's say we have a patient with recurrent implantation failure or recurrent pregnancy loss, and we did all of this immune testing that we have talked about in earlier episodes. And we have discovered that the cytokine ratio is elevated. Now what? What are some of the potential management options?
Yes. When it comes to elevated cytokines, there are so many options, which is why this ballooned into a whole episode in and of itself. On today's show, we're going to talk about intralipid infusions, oral steroids, immunoglobulin therapy, as well as immune modulating medications, specifically TNF Alpha Inhibitors. And then we're also going to talk about hydroxychloroquine and tacrolimus.
Let's start with intralipid therapy. Intralipids are an IV infusion of fat originally used for nutrition. It is also used in patients who get lidocaine toxicity from very high doses of local anesthetic. It basically is fats that come from soy, peanut, and eggs. So if you have an allergy to any of those, intralipids would be contraindicated for you.
The evidence for using intralipids to decrease cytokines in the world of reproductive immunology is pretty limited, and it's primarily indirect, with most studies actually looking at natural killer cell activity rather than cytokine levels specifically. The proposed mechanism in terms of how they work involves the inhibition of pro-inflammatory mediators. So again, that works to decrease inflammation. Early research has demonstrated that these intravenous fat emulsions can potentially inhibit the pro-inflammatory mediators, although really the specific mechanisms are very unclear. And fact is, direct data looking at cytokines is really sparse.
However, clinical outcomes actually show some promise in selected populations. For example, there was a meta-analysis. Remember that meta-analysis is a combination of multiple studies that demonstrated that intralipids reduce both the natural killer cell levels as well as the natural killer cell activity in patients with recurrent pregnancy loss. There have been multiple studies showing a good live birth rate in women with elevated natural killer cell activities treated with intralipid, although these are primary observational studies that have some methodological limitations. The current evidence would suggest that intralipid may actually have immunomodulatory effects, but a well-designed randomized controlled trial specific about treating cytokines in the setting of recurrent pregnancy loss or recurrent implantation failure still needs to be done, and unfortunately probably will not be done anytime soon.
Just because those studies involve way too many people, be far too expensive, and you can't really randomize people ethically in the world of fertility so much with this. Yeah. Now, the good thing about intralipids is that it is quite a safe treatment with really minimal side effects. Unless somebody has an allergic reaction, of course, and as we talked about the soy, peanut, and egg, the effects are fairly benign. We typically will give intralipids prior to an embryo transfer. So you're getting them before you're actually pregnant. So there's not really any risk to the pregnancy that we know of or any risk to baby.
At Market Fertility Center, after very extensive discussion about all the things related to the immune testing and treatment, if a patient has elevated cytokines and is considered intralipid therapy, we typically do 3 infusions, each about 2 weeks apart, and then we retest the cytokine levels to make sure that the levels are appropriate or the ideal that you want to see for implantation prior to an embryo transfer. And then we give intralipid again about 4 to 6 days prior to that embryo transfer.
Intralipids can be a very reasonable first line option for treating elevated cytokines in the context of recurrent implantation failure, recurrent pregnancy loss. Again, these on balance, they're pretty safe, pretty benign when we consider risk to the person carrying the pregnancy itself, and pregnancy related complications.
Now that we cover intralipids, let's move on to another option, which is the use of steroids. One of the steroids that is most commonly used in this setting is prednisone. And prednisone is an immune modulated medication, very much used in medicine for a variety of autoimmune conditions. These are oral pills that are relatively inexpensive. Again, lots and lots of data on the safety of prednisone, as well as the potential side effects. They work by suppressing the immune system and are used, like I mentioned, in many different autoimmune disorders outside of the worlds of fertility.
The evidence for using oral steroid medications to decrease elevated cytokine levels in the world of reproductive immunology has been established mechanistically, but it's clinically inconsistent with really limited data. So, what that means is that in the lab, under the microscope, they've established that steroids will decrease cytokine levels. But when it comes to actually seeing that happen clinically, when you're looking at a patient, there is just very limited data. There's also limited data showing that decreasing cytokines with the use of steroids will then improve pregnancy outcomes as well. We're not necessarily showing that leap, that next step in terms of what we have in the data. It's worth mentioning, though, that steroids do have very well documented anti-cytokine effects. In a reproductive context, prednisone for sure has been shown to normalize cytokine expression and suppress inflammatory mediators. But again, those clinical outcomes remain disappointing despite the fact that research has shown that cytokines do end up getting modulated. The largest randomized control trial, which included 329 patients, found actually no difference in live birth weights between people who took prednisone or placebo in patients with recurrent implantation failure.
Yeah, as a matter of fact, multiple randomized controlled trials have shown no improvement in implantation or pregnancy rates when patients use steroids pre implantation. There was a systematic review in 2021 that concluded that there is just not sufficient evidence to recommend steroids as part of immunotherapy in preventing recurrent pregnancy loss. The largest and most rigorous randomized controlled trial found no correlation between cytokine modulation using steroids and improved reproductive outcomes in patients with recurrent implantation failure. This was published in 2023 by Sun et al. In the Journal of the American Medical Association, and it is considered the most definitive study to date on this subject. It was a multi-center, double-blind, randomized controlled trial of 329 women with recurrent implantation failure, where they used 10 milligrams of prednisone every day versus placebo. And this went from the point of pre-implantation period all the way through early pregnancy. The study did not specifically measure cytokines or the effect of steroids on cytokine levels.
Despite prednisone's established anti-cytokine effects, the clinical benefits have not really been shown in well-designed studies. There was one RCT, however, that specifically measured cytokine changes. It was published in 2021 by Huang et al., and they demonstrated that 10 milligrams of prednisone on a daily basis significantly decreased interleukin-17 levels and increased interleukin-10 concentrations, specifically in RIF patients. Again, this shifted the Th1, Th2 balance to being a more favorable, more immune-tolerant ratio. Now, in this study, though, only 5 of the 19 patients achieved pregnancy, and there were 4 live births. This is a relatively low number. And again, there was no control group that was included to determine if this actually represented an improvement or not.
Also, the use of steroids do come with potential risk. In the context of low-dose prednisone used for a short term, The most common side effects are usually a metabolic disturbance. That would be, for example, elevated blood sugar, elevated blood pressure, or some weight gain. Although serious adverse events could happen, but they're relatively uncommon. Adrenal suppression can occur even with relatively low doses when used chronically. So, this is why we want to use steroids if we're going to use it only for a short period of time in the peri-implantation period, and then we want to taper the medication once you stop it because we want to make sure that we give a chance for the adrenal gland, which is was actually making steroids, to come back and not cause adrenal insufficiency.
We also need to consider baby's well being. So, the American College of Obstetricians and Gynecologists notes that while early data suggested that if you take steroids in the first trimester, it might be associated with an increased risk of cleft lip or cleft palate, more recent data has actually failed to demonstrate this association. That being said, taking steroids in pregnancy can potentially increase risk of preterm birth, low birth weight, admission to NICU, and potential neurodevelopmental effects that we just don't really understand quite yet. But again, the dose of steroids, the duration of exposure, meaning how long you're taking the steroids for, and the timing, meaning, is it going to be in the first trimester versus second or third trimester, will change the relative risk of these things.
Whenever we're considering treatments that are not evidence based, or in other words, there is no evidence that it works, it is important to have a discussion weighing the potential risk and the potential benefits for it to be really about shared decision making and proper informed consent.
Certainly, I think what we can say is that with steroids, they will help decrease those cytokine levels, and that has been demonstrated. But we don't necessarily know if they're going to improve the pregnancy rate. And again, we have to consider potential risk to the person carrying the pregnancy and risk to baby. But on the flip side, they're relatively inexpensive and they're very easy to take. They're very easy to administer. It's just a daily pill.
Yeah, and ultimately, I mean, in that study with only 4 of the 19 got pregnant, like again, pregnancy rates, there's so many factors. It's not just about the cytokines.
Yeah.
So maybe it does decrease cytokines. And maybe if those patients had different age, better embryos, different endometrial lining, so many other criteria, then it would have shown a benefit.
Yeah, exactly.
We just don't know.
Absolutely. And I mean, as we know, whenever we're actually working with patients, we're rarely ever just doing one thing, like just adding steroids. No, we're doing
A lot of
17
things.
things all at the same time. We're changing all things up with every transfer. And so it's really difficult to even know what is the thing that made the difference.
Another potential treatment option to lower cytokine levels is a class of drugs called TNF Alpha Inhibitors, and they include medications such as Humira and Symphony.
These medications are often discussed in like online forums and immune fertility clinics, and they can sound really compelling because they are literally TNF alpha inhibitors. But, they're also complex, powerful drugs with very specific indications.
Yeah, these drugs were developed for autoimmune and inflammatory disease specifically, such as, for example, rheumatoid arthritis, Crohn's disease, and psoriasis.
Absolutely. I mean, in those conditions, these drugs can be life changing, right? They reduce inflammation, improve symptoms, and prevent organ damage. So, these drugs are commonly used in those conditions. And so there's a lot of data about them and safety data.
Infertility, however, it is off label use. It means that were not developed for that purpose and they were not approved specifically for reproductive purposes.
There have been some observational studies demonstrating a potential benefit. In women with unexplained recurrent miscarriages, the use of a TNF alpha inhibitor in the study, though, they combined it with heparin, which is a blood thinner, they achieved a higher live birth rate than in the control group. It was about 71% to 51%, with a particular benefit in women under 35 and those with 2 prior miscarriages and a normal BMI.
The American Society of Reproductive Medicine guidelines noted that these results were, quote unquote, interesting but unreplicated. A systematic review found insufficient high quality evidence to support routine immunotherapy use with steroids, even when selected on the basis of abnormal or elevated cytokine levels.
Now, current evidence seems to support the use of a TNF alpha inhibitor as a potential option for carefully selected patients with a documented immune dysregulation and recurrent pregnancy failure. Really, sort of talking about patients who are known to have antiphospholipid antibody syndrome. But again, Prospective randomized trials are needed before we can sort of adopt these things and use them more routinely.
It's important to note that these medications are not benign. By suppressing TNF alpha, you are suppressing part of the immune system. And some of the potential risks include increased risk of infection, reactivation of latent infections like TB, for example, or an injection or an infusion reaction. And of course, let's not forget, again, the cost of these medications.
Another potential treatment option for elevated cytokines that we'll discuss with patients is the use of immunoglobulin therapy, or IVIG. IVIG is a medication made from pooled antibodies from the plasma of thousands of healthy blood donors. Antibodies are proteins that your immune system normally makes to fight infections. So when we look at this in IVIG, these antibodies are purified, concentrated, and in the case of IVIG, are given through an IV infusion.
IVIG demonstrates immunomodulatory effects that shift the cytokine balance towards a more Th2 dominant anti inflammatory profile.
Yeah, we went into a great deal of detail about that in episode 87, and that was a very highly sought after episode talking about cytokines, part one. The strongest evidence for the use of IVIG comes from a 2022 double blinded RCT study in women who had 4 or more unexplained pregnancy losses, which found that using high dose IVIG every 4 weeks at about 4 to 5 weeks of pregnancy significantly improved live birth rates compared to placebo.
Observational studies also support these findings. In one study of 44 patients with recurrent pregnancy loss, IVIG treated women achieved actually an 87.5 live birth rate versus a 41% live birth rate in untreated controls. And this was with a documented shift in the Th1 to Th2 balance. Another study showed IVIG increased live birth rate to 86% versus 42% in the untreated patients, while also modulating regulatory T cells populations. For recurrent implantation failure, evidence is more limited. The American Society of Reproductive Medicine guideline notes that only 2 small randomized controlled trials with mixed results exist. One showing improved implantation rates, but the other one was showing no improvement in implantation rate or live birth rate.
The American Society of Reproductive Medicine guideline on IVF back in 2018 found that there was really insufficient evidence to recommend routine IVIG use, even when you were selecting based on abnormal cytokine cell levels. And again, the systematic reviews that have looked at all of these studies and have pooled these studies have shown that there's really high heterogeneity amongst these studies. And note that most positive results, meaning the studies that showed that IVIG worked, came from observational cohorts that had moderate to high risk of bias. So let's break that down. What does that mean? Heterogeneity among studies means that, when you are trying to pool the results, you're really kind of comparing apples to oranges. And again, as we've talked about, ad nauseum, these are very, very difficult patient populations to study because we have not even standardized the definitions of what is RIF and what is RPL and what are normal and abnormal cytokine levels. And with the risk of bias, when the study is just an observational study and there's no control group, we know that that evidence is just not as powerful because the study has not been created in a way to give us really good definitive answers. But they're much easier to do. So sometimes that's kind of the best evidence that we can get.
Now, if you're a Market Fertility Center patient, you might be wondering, wait a minute, they're talking about IVIG, but I got something called SCIG, which stands for subcutaneous immunoglobulin. So let's address what that is. IVIG and SCIG are essentially the same thing. It just changes how they are administered. IVIG is given through the IV, it's intravenous, whereas SCIG is given subcutaneously. You get a small needle below the skin. Our own amazing one and only Dr. Chen actually did a study that hasn't been published yet, but it was submitted as an abstract at CFAS. And she was comparing the pregnancy rate between SCIG and IVIG in both recurrent pregnancy loss and recurrent implantation failure population. The pregnancy rate after SCIG was the same as the pregnancy rate after IVIG.
It's important to know that immunoglobulin therapy, whether it's IVIG or SCIG, is generally really well tolerated, but it's not risk-free. There can be possible side effects, including headaches or migraines. Sometimes people will experience flu-like symptoms or fatigue around the times of infusion. Rarely, people can get an allergic reaction or blood clot, again, which is very rare. And you have to keep in mind that this is a blood product, right? You can think of it as being in the same vein as getting a blood transfusion. Oh, I think that was a good pun.
I can never take you anywhere.
What I'm trying to say is that with a blood transfusion, there's always risk of infections and all kind of transfusion reactions. Again, because this is just a very small proportion of blood and it's not like a red blood cell transfusion, those risks are a lot less and a lot lower, but it's not zero. So it's something to be aware of.
It's important to know that in Ontario, IVIG is just not available for fertility clinics in general. So it is not something that we can offer our patients at all. SCIG, on the other hand, we are able to access it through Canadian Blood Services, but only under specific circumstances. And there is a very strict criteria that has to be met for us to be able to order SCIG for our patients.
As we're moving through different treatments for elevated cytokines, next on our list is tacrolimus. Tacrolimus demonstrates significant immunomodulatory effects, and we know that it reduces Th1 cytokines. And again, it also shifts the Th1 Th2 balance towards a more pregnancy favorable Th2 dominant state.
The strongest evidence comes from a 2023 randomized controlled trial in patients with recurrent pregnancy loss that had elevated Th1 Th2 ratios. Tacrolimus treatment achieved an 80% live birth rate versus a 63.5% live birth rate with placebo, while also significantly reducing peripheral blood Th1 Th2 ratios in patients that were treated.
In the world of recurrent implantation failure, there was a prospective cohort study that found that tacrolimus treatment achieved a 64% clinical pregnancy rate and a 60% live birth rate in patients who had an elevated Th1 Th2 ratio, compared to 0% in untreated controls.
Another prospective observational study of 109 women with recurrent implantation failure and recurrent pregnancy loss treated with tacrolimus before and during pregnancy found that there was no significant obstetric or perinatal complications.
The 2018 ASRM guideline on IVF and immunotherapy noted that these results were promising from the initial studies, but they cautioned that findings should be interpreted carefully due to selection bias from a lack of randomization and small sample sizes. Looking at the designs of these studies, although the results were really good, these studies weren't sort of the best, highest quality studies based on their designs. The guideline also emphasized that while the mechanism is biologically plausible, given we know that tacrolimus inhibits Th1 responses and promotes immune tolerance, larger randomized controlled trials are needed before we can adopt this routinely across clinics.
So we've talked so far about Intralipids, about steroids, IVIG, and SCIG. We talked about tacrolimus. So now we're going to talk about another treatment option for elevated cytokine levels, and that is a medication called hydroxychloroquine. Hydroxychloroquine, again, demonstrates immunomodulatory effects by shifting the Th1, Th2 cytokine balance towards a Th2 dominant state, just like all the other ones that we mentioned before. And there is emerging evidence suggesting that there is a benefit in patients with recurrent implantation failure and recurrent pregnancy loss. In women with recurrent implantation failure that have an elevated tumor necrosis factor alpha, hydroxychloroquine significantly decreased the levels of tumor necrosis factor alpha and increased the levels of IL-10, which again, from the prior episode, you know already that this is shifting the Th1, Th2 ratio towards the Th2, which is more anti-inflammatory.
So, in the world of recurrent implantation failure, for patients with autoantibody positive status, so what are autoantibodies? This refers to the presence of one or more antibodies, including antiphospholipid antibody, anti-nuclear antibodies, anti-thyroid antibodies, and others that are potentially associated with immune dysregulation. So for those patients who have these antibodies and are undergoing a frozen embryo transfer, hydroxychloroquine treatment has been shown to significantly improve implantation rates, clinical pregnancy rates, and ongoing pregnancy rates, while potentially reducing the risk of biochemical pregnancies and early miscarriage rates.
Now, in recurrent pregnancy loss, the evidence for unexplained recurrent pregnancy loss is more limited and more conflicting. There was a large French prospective multicenter trial that looked at 100 pregnancies in women with recurrent pregnancy loss and found that hydroxychloroquine exposure did not actually prevent further miscarriages. Hydroxychloroquine at standard doses, which is less than 400 milligrams a day, has actually shown that there is no association with congenital malformations. And both large studies as well as international guidelines have confirmed that it is safe to use during pregnancy.
With hydroxychloroquine, as with all of the other treatments that we've talked about, there certainly have been some promising studies. But again, as we have said countless times during this episode, more larger randomized controlled trials are needed before we can make definitive conclusions and sort of use hydroxychloroquine routinely. The benefit of hydroxychloroquine is that at least we know that it's safe and that the side effects for the person taking it are relatively mild compared to other drugs.
We've covered a lot so far in this episode.
Mhm.
Now let's talk about sort of big picture. We know there's all of these options available. We know about TH1, TH2. So how do we counsel patients? How do we talk to patients about immune treatment? When patients come and say, hey, I want to do immune treatment, how do we approach that? We basically look at 3 questions. One is, have all the other causes of recurrent pregnancy loss and recurrent implantation failure have been evaluated? The uterine cavity, the genetics, the quality of the embryos, the quality of the eggs, DNA fragmentation, the lining of the uterus. I mean, all of those things.
Mhm.
And we talked about all of those things in another episode as well. Do we know if there is a known autoimmune condition like antiphospholipid antibody syndrome or elevated cytokines? And then we talk about what the risk, the cost, and what are the realistic expectations for each individual patient.
Along with that, knowing that there may be potential negative effects of some of these immune treatments when somebody doesn't necessarily have those conditions as well. Because even though the studies have looked at patients with elevated cytokines and what the effect is, if you don't have elevated cytokines, then maybe using these medications may actually be detrimental.
Exactly.
And we don't know about that. We always emphasize that immune therapy is not some magic fix. It's not like a silver bullet. It's not a magic pill, right? And unfortunately, the truth is that for many patients, it may not change outcomes. But, and this is the big but, it is important to have these discussions so that, together between the patient, the physician, it's a shared decision-making model in terms of how to move forward so that the patient can feel like they have turned over every leaf, they've turned over every rock on their journey.
Mm-hmm. Yeah, and ultimately, patients are no guidelines, right? Patients are patients.
Yes.
And I think it's important that we look at each patient individually because they all are individuals, and we don't apply general population statistics to the individual case and limit choice and options for them.
It's also important, I think, at this point to talk about the emotional impact of all of this. I mean, repeated implantation failure, repeated pregnancy loss, you cannot overemphasize how emotionally devastating these things are, right? There are no words really to describe how these things can affect the patient, the partner, the relationship, and everything else going on in their life. And I think it's really, really important to come back to that, right? Because we want to help people. We want to do the best by people and the best for our patients. Absolutely. And we want to minimize their suffering, frankly, as much as we can. And when we are working with patients with recurrent implantation failure or recurrent pregnancy loss, that is really, really important piece of the puzzle.
With all of these episodes, really our goal has been not to say, yes, you should do it, no, you shouldn't do it, but to give you all the information and all the knowledge so that you're armed with all of that when you're talking with your fertility doctor. And at the end of the day, we want to help. Fertility doctors really want to help. We know that hope is really important. And if you are my patient, you know that I like to be a cheerleader and that I really believe that patients need to believe in themselves, but it's also really important that we protect patients from unnecessary harm, increase financial burden, and false promises.
So really, immune treatments for elevated cytokines, we are sitting at the edge of scientific discovery here. They are promising in theory, but we're still lacking strong evidence.
If you're considering these treatments, have an open and honest discussion with your fertility specialist.
You absolutely should ask about what is the evidence? What do the guidelines say? What are the alternatives? What are the risks to the person carrying the pregnancy, risks associated with the pregnancy, risks potentially to baby, and how will success be measured?
And remember, this is the thing I want to leave you with. Unexplained does not mean hopeless.
Now, there's still more to talk about when it comes to reproductive immunology. So stay tuned for the next episode in our series, where we're going to be talking about SCIG, or subcutaneous immunoglobulin therapy specifically. And we're going to be joined by our very own Dr. Crystal Chan. Stay tuned for that episode. And that's a wrap for today, Superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast or visit us online at mycanfertility.com. And don't forget, follow, subscribe, and share your favorite episode.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss. Music, Island Memories, instrumental by Descript stock music. My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.